So today we are going to be discussing about a recent case that we came to know about, that a 25-year-old had a mini stroke or a transient ischemic attack, and according to the information that has been provided, that she was in OCP despite of migraine. Usually we know that migraine is an absolute contraindication, okay, for oral contraceptive pills, but she was taking them despite her migraine, and there was a history of a long flight because of that immobility and a history of COVID. So we know that all of these things contribute to a clot formation, right? Clot formation and embolus can be formed from these factors. And then on investigations, we realized that there was a patent foramen ovale which was very significant. So let's first discuss the transient ischemic attack. So according to the older definition, they used to say that, when neurological symptoms occur and they are reversible, reversibility is what defines it. They are reversible within 24 hours, completely reversible. We call it as a transient ischemic attack. But according to the newer definition, they usually last for less than 1 hour. This is the latest absolute definition. The threshold is 1 hour, but the older threshold was 24 hours. Okay, so they are completely reversible. So why does it happen? Basically, we know that the brain has a blood supply, and let's say this portion is being supplied by blood. Now if the blood supply to a certain portion decreases, then the functionality will be reduced and the patient might suffer from loss of functions of controlled by that part of the brain. But if this decrease in the blood supply is long enough, okay, due to any clot, okay, then in that case there is going to be a stroke. But if it is for a shorter time period and it is, it comes back and it is reversible, then in that case it is known as a mini stroke. Okay, don't mind the children screaming. A mini stroke or a transient ischemic attack. So in this case, the patient's blood flow was reduced for a very smaller period of time and it was replenished, so her symptoms also resolved gradually. So that is why we call it as a transient ischemic attack. Now what are you going to do with the patient? You know the history, you know that this is a transient ischemic attack. Is there any further thing that needs to be done? Yes. Theoretically, you have to calculate the ABCD2 score for a patient who comes to the hospital. What is the ABCD2 score? We have A is for age, okay, and if the age is more than 60-year old, then we give it a score of 1, okay, and then B is for blood pressure, and if it is more than 140/90, which means that if the patient is a hypertensive, then we again give a score of 1, and then C is for any clinical symptoms, okay, and for clinical symptoms we give 1 point for speech loss, 1 point for weakness, and if speech loss and weakness they happen all together, then we give a score of 2. Okay, and then we have D2, right? So there are two twice the alphabet D is there. With the first D we have diabetes mellitus. If the patient is diabetic, then in that case there is again going to be a score of 1, and the other D is for duration, like what was the duration of the attack. Okay, if the duration is less than 1 hour or more than 1 hour. If it was less than 1 hour, then we're going to give it a score of 1, and if it was more than 1 hour, then we're going to give it a score of 2. Right, so all of these things we have the ABCD2 score. Now how do we interpret it? If the total score is more than 4 or equal to 4, then we have to admit the patient, otherwise the patient can go home. Now also it predicts the risk, whenever there's a mini stroke, there's a very high risk of stroke later in life or in the upcoming days. So if it is higher, then we know that there's a higher risk of stroke on the 2nd, 7th, 30th and 90th day, and the risk percentage increases with the score. Okay, so this is the importance of the ABCD2 score. Whenever talking about the transient ischemic attack, you must always know about the ABCD score. They are going to ask how are you going to do the workup of the patient. First of all, we have the general investigations, which include the complete blood picture of the patient. You are going to do the blood glucose, and you are going to do the blood, lipid profile, all of these things to rule out, any disease. Lipid profile needs to be done. If the BMI of the patient is high, then you might suspect that this is because of obesity. The patient is having atherosclerosis. Now, the specific workup includes you have to do an echo, you have to do an EKG, you have to do a 24-hour EKG monitoring, which is known as a Holter monitoring. You have to look whether the carotid artery, which divides up to supply the brain, is whether it is stenosed. So you have to do a carotid duplex ultrasound. So you have to do all those things. And the best investigation when a patient, and because a patient comes to you, you don't know that whether this is a mini stroke or a stroke, because this is the first hour of presentation, let's say. So the first investigation when you are suspecting a stroke, what are you going to do? You are going to basically do a non-contrast CT. Okay, this is a no-brainer. Since this is a mini stroke, so I skipped it and I talked about detail. But when the patient presents to you right away, because if the patient has facial drooping, unable to talk, weakness, send for a non-contrast CT and look for any ischemic area. So if there is no ischemia, and symptoms last for less than 1 hour, then this is probably a transient ischemic attack. But if there is ischemia, if there is, you can say, no bleeding, then this rules out a hemorrhagic stroke, and the symptoms last for more than a few hours and they are irreversible, then this is probably a stroke. And to see ischemia, the non-contrast CT is not going to help you. The non-contrast CT is only going to help you to rule out a hemorrhagic stroke, which is our first priority. Okay, in order to rule out ischemia, you need to do an MRI. Okay, which takes up time, which is supposed to be done later. Okay. Okay, so how are we working up the patient of a mini stroke? We did an echo, EKG, all these things. Now, let's say, as in our case, the patient is young. What is one thing that you need to do? You always need to rule out a patent foramen avail, because it is very common. It is present in up to 30% of our population. So this might be the cause. So for patent foramen avail, we have a special study in which what we do is that we do an echo, okay, and probably a transthoracic echo or a transesophageal echo. Echo can be done by these two modes, an echo with a saline contrast. I don't know the details, but this is basically the investigation that we do to rule out PFO, and this is known as a bubble study. Now, why are we calling it a bubble study? Because in this study we see that, let's say that this is the left atrium. Okay, no, sorry, this is the right atrium, this is the left atrium. So if there are any bubbles in the left atrium, any sort of bubbles, there should be no bubbles in the left atrium. This means that PFO is present. Now then we grade the severity of this PFO based upon the number and the size of bubbles. We grade it. Okay. So this is the study that we do for patent foramen avail. So why is it very dangerous to have a large patent foramen avail? Is because let's say that this is a hypothetical heart and this is a patent foramen avail. This is the right atrium, the left one, the right ventricle, the left ventricle. So what happens is that since we know that the patient had a lot of factors which led to hypercoagulability and led to a clot formation, and which later embolized, so an embolus was present. Okay, now what happens is that in a normal person, what happens that this embolus goes to the, let's say, to the right atrium via the veins, from the arteries to the veins into the right atrium and then the right ventricle, and then it goes towards the lungs where it is filtered out somehow. They absorb it, and then into the heart nothing enters. Okay, the embolus does not enter, so it is not that dangerous because it cannot go to the brain in this case, because brain is very sensitive to anoxia. But in this case, when the foramen avail is patent, this embolus, let's say this is the embolus, it will directly enter the left atrium via this hole. Okay, it will not go into the right ventricle and into the lungs. So when it will directly enter the left atrium through the hole and then to the left ventricle and then through the aorta and then to the brain, then it will definitely cause a stroke, or in this case, a mini stroke. Okay, so this is the mechanism, and this embolus, which goes to the foramen vein directly from the right atrium to the left atrium, is known as a paradoxical embolus. Okay, always in a young patient of stroke or mini stroke, always consider a paradoxical embolus. Rule it out by investigating for patent foramen vein.